guys, Miss Parnell back for the second part of the therapy notes. This is the biomedical part of the therapy notes. We've already done the psychotherapy stuff, which is all the different types of talking therapy and stuff. So now that we're going to look at the more medical stuff, drug therapy and things like that. So this is the second of two parts of your Google Slides. Here's your crash course that you can watch. So make sure you go do that. If you haven't already, watch it and then come back. Again, I need to make these come in one at a time, or we'll see. So biomedical therapy. Again, this is the slow one where I write with you. So let's write that down. So biomedical therapy. This is prescribed medications or procedures, like a surgical procedure. That act directly on the person's physiology. So that act directly on the person's physiology. So it's like the whole biological concept. So physically, it's like changing the brain's functioning by altering its chemistry with drugs, or it'd be like affecting the brain's circuitry by doing something called electroconvulsive shock, which we'll talk about, or something called magnetic impulses like magnetic stimulation and stuff we'll talk about, or doing some type of surgical procedure. And if the surgery is for like psychological help and it's for therapy, it's called a psychosurgery. Or they'll try and influence it by having people change their lifestyle. That's kind of how we end the notes with things like exercise, diet, sleep. All those things can actually help too if you don't want to do anything too medical. This is how I broke it down. You don't have to write this down unless you want. If you want, pause it and write this down. But remember on the last one, it was like psychotherapy, and I was like breaking it down for you as like psychodynamic, humanistic, behavioral, cognitive, that type thing. Well, this is what I'm doing here, but there's just a lot more subsections. So there's really like four main ones, kind of like there was like the psycho, the humanistic, the cognitive, like there were four main ones in the last one. There's four main ones here: drug therapy, brain stimulation, psychosurgery, and then therapeutic lifestyle change. That thing to go away, but it pops up every time I move the mouse. So those are your four main components. Then there were several things within each component, which happened in the last one too. Like in behavioral, there was like counter conditioning and then aversive therapy and virtual reality. And there was a ton of things like that. So this is kind of just organizing it for you. So within drug therapy, we're going to talk about antipsychotic drugs, anti-anxiety drugs, antidepressant drugs, and mood stabilizers. We get to brain stimulation. We're going to talk about electroconvulsive shock therapy, magnetic stimulation, deep brain stimulation. The only main surgery we're really going to talk about is a lobotomy, and then therapeutic lifestyle change is just a bunch of things. I mean, there's a million parts to your lifestyle, right? So it's changing stuff like that. There's a pretty cool video you can watch. It's made by Philip Zimbardo. Okay, so you remember Zimbardo was the guy who did the prison experiment, the Stanford prison experiment, dark hair, kind of older guy. I told you he did it at Stanford University because he's a very famous psychology professor, probably the most famous psychology college professor, period. And sometime in like the 90s, I think it was, these videos are kind of old, but they're good. He made like a video series, like this huge video series. So like when I was in psychology, when I was in honors psych at Glenn, when I took AP Psych at the Career Center and have it at Glenn or any homeschools, when I was taking psych classes in college, we would watch clips from these Annenberg series. And it's basically Philip Zimbardo talks about every single thing in psychology. Everything I've talked to you about, he has like video clips on it, and they're grouped by like huge topics and units, kind of like the units we do now. I could really just like have you watch this like, I don't know, however many hour series. I mean, it's probably 20-hour series, and you would learn literally everything about psychology. I need to put more of his clips in. They're just older, but they're still good, and they still explain stuff. So anyways, go watch that clip if you have time. You want to pause this and watch it. It's pretty good, talking about different types of biomedical therapies and stuff and how they help. And you can Google him and find clips. Like if you want to do that when you're reviewing for the exam, if there's like something you don't know, you can Google it. And literally it's him teaching it. And he's a really good teacher. So, I mean, he's no me. JK. So anyways, all right. So the first section is drug therapy. All right. So let's make that the first of the four types of biomedical therapy sections in our notes. So drug therapy. And if you want to write down first off, I do want you to somehow sum this up, that it's the most common. It's the most common type of biomedical theory. Not the most common type of therapy. Most common type of biomedical is that people just take drugs before like surgeries and stuff. And then let's get the definition of drug therapy. Drug therapy is technically called psychopharmacology. You know what, a pharmacist and a, pharmacy and all that stuff is. So pharmacology is like the study of medicine and stuff, what a pharmacist does. Psycho, the prefix that, again, we're talking about things that mess with your psyche and your brains. We're not talking about, medicine for cancer, for high blood pressure. We're not talking about Advil. We're not talking about anything like that. We are talking about, things that work with your psyche. And psychologically help you and help psychological disorders and stuff. So this is called psychopharmacology. Let's write that down. It's a long word. All right, so your definition: the study of the effects of drugs. No, of drug, don't plural it. Effects of drug. No, it should be. I just didn't type it right. Of drugs on the mind and behavior. I'm gonna check that with the book. I might have forgot words like the or plural. But the study of the effects of drugs on your mind and on your behavior. So we talked about this in Unit 1, flashback. If you took honors psych, you should remember talking about this. To evaluate the effectiveness of a drug, right? They do a couple different things. They have a group of people they're going to test on. So first off, you got to split them in half. And before you do that, which they talk about, I think it was in the crash course, it's in one of the videos here, they talk about how you need to random sample to get these people, and then random assignment who's going to be in what group, just to keep all your, just to keep it genuine and stuff like that. And legitimate and all. So, once you do that, you got your two groups. One group needs to get it. They are the independent variable because the independent variable is the drug. And so they are your experimental group. One group needs to not get it. Okay, they're going to get a placebo, a fake thing, and they are your control group, your baseline group. So you're comparing what happens with the pill, the experimental group, to the control group that didn't. Remember, a placebo is a fake thing. It has no properties to it. But you can't let half the people pop a pill and half the people not, because if they know they're in a drug study and they didn't take a pill, you know what I'm saying? So everyone, and if you're the researcher, you need to see everyone taking a pill, because you don't want to know these guys got it and these guys didn't. So I'm not even gonna waste my time looking at them. I'm gonna look at these because you could miss something. So remember, they give half a pill or the drug, half not. Experimental group, control group. Independent variable, dependent variable. Yes. Dependent variable is more like the effects of the drug, but anyways, I'm going way back into Unit 1 too much. And when they do that and the researcher doesn't know, that's considered a double-blind procedure. So neither the participants, that's the first group being blind, neither the researchers, that's the second group being blind. Since there's two, they call it double. And some third-party outside group that's not involved in it knows who got what, and at the end, they reveal the results. So the researcher can then look at the data and decide, was the drug effective or not, basically. That's just what's kind of talking about down here. All right, so our first type of drugs in drug therapy are antipsychotic. And you're probably like, what? Psycho? I know it sounds kind of crazy. And that's because it is the heavier stuff. These are not light medications by any means. So antipsychotic drugs, we'll write the definition of that. These are drugs used to treat schizophrenia and other forms of severe thought disorder. So these are your psychological disorders that are heavy, that are crazy, that could be bad, violent, scary, stuff like that. So these are very powerful medications. Now, what you will note, and you can read it in your book, you'll know it when we talk about stuff, is as we move through these drugs, these are not drugs that would ever need to be mixed with alcohol, like street drugs, like marijuana or anything like that. These are not drugs that need to be mixed in a combination in a person's body with anything else. I mean, there's probably some over-the-counter drugs and stuff. They don't need to be taking sleeping pills with this. They don't need to be popping maybe Advil or Tylenol or so. I mean, these are very powerful drugs. And so when you hear instances of someone who maybe OD'd and it wasn't like they were trying to, it was maybe they were depressed and they were on an antidepressant, or they were anxious, they were on anti-anxiety, they were on an antipsychotic, and they drank too much, or they drank and they did some drugs. And the drugs, the alcohol, the prescription drugs, you know, just made a concoction inside the body that basically killed the person. So these are very powerful drugs. But see, the other catch is a lot of times people who suffer from psychological disorders try and self-medicate. You know, they try and take a bunch of sleeping pills. They try and, you know, do recreational drugs. They try and drink alcohol. They try and like escape stuff, right? So you got this like conundrum of like, you can't do that, but these are people who are maybe more prone to do that. So these can be very deadly. These can be very harmful. So just kind of keep that in mind as we're going through. These are very powerful because they are literally manipulating how your brain works. So it's insane how powerful these drugs are. The two most famous types, no, you can write these down for all these. I put like examples in case you've ever heard them, you would know. I don't think you would necessarily ever need to know, so I'm gonna leave that up to you if you want to write down the examples or not. But the examples are Thorazine and Risperidol. I think in the video, the 2020 video with the schizophrenics at the first part of the different Google slide, the psychological disorders, they were taking Risperidol. That's kind of a new one. Thorazine's kind of how it started out. And your book talks about how we came across these and kind of like stumbled upon them. And that was like one of the first ones and stuff like that. They dampen someone's responsiveness to irrelevant stimuli because people who are schizophrenics a lot of times have auditory hallucinations and stuff like that. And they're experiencing things like paranoia. And it's all this irrelevant static basically in their brain. And so this kind of eliminates that so they don't hear things or see things or think things that aren't real. So it kind of helps with that. And you got a video you could watch. Here's how they work. Again, I'm not going to make you, this is up to you. If you want to write down, I kind of explain how all of them work. This is up to you if you want to write it down or not. I can't see you needing to go this much in detail on a final exam. I mean, this is probably like, you know, like you're becoming a therapist or counselor or something like that, or like a chemistry degree. But anyways, I'm going to tell you about it because your book does tell you about it just so you can understand. So and you feel free to write it if you'd like to know. So dopamine, if you remember back at the beginning of the year, talking in Unit 2 about neurotransmitters and stuff like that with the brain, dopamine is the neurotransmitter associated with schizophrenia. And so this works with dopamine. And so what it does is it makes like molecules that are similar to dopamine in the brain. And so it goes in the brain and like occupies the spots where dopamine should be, like the receptor sites, and it blocks some of the like activity, dopamine activity that's not needed and stuff, because overactive dopamine contributes to schizophrenia. And so that's kind of how it like puts the person back to normalcy and like makes them live in reality. There are powerful side effects though. Like I said, these are very powerful drugs. Tremors, twitches, like physical shakes, kind of stuff like that, similar to Parkinson's, can be developed with this. Because Parkinson's is when you have too little dopamine. If you remember that back to the beginning of the year, we said when you have too much, you're flooded, that's schizophrenia. When you have too little, that's Parkinson's, which is kind of a shake, just like old tremors, twitches. And so depending on the medication and what the person's doing in life, you know, they can have side effects. But this medicine, antipsychotic medicines, Thorazine, Risperidol, are very, they're very good. They're very, what's the good word? Like they're very, I guess it's good. You know what I'm trying to say. Like they work. There you go. And so when you combine those drugs with therapy, like going to therapy, learning new ways of thinking with cognitive therapy, you know, or behavioral therapy, reinforcing good behaviors, not bad behaviors, whatever type of therapy you talk about. You're going to therapy and you have a supportive family, because schizophrenia, you know, like we talked about, the person is not in reality. So as much as I'm trying to tell you what you're experiencing right now is real, I'm trying to tell them that what they're experiencing right now is not. And they're not going to believe me. Like, you're not going to believe me right now if I'm like, this computer in front of you or you know, iPad or phone or whatever you're watching isn't real. My voice isn't real. You're like, yes, it is. I'm watching you, Miss Parnell. Like, what are you talking about? So somebody would have a very hard time convincing you right now, like everything you're doing right now is like made up. You think they're crazy, not you. Well, that's kind of the mind of a schizophrenic, because they're hearing and seeing things and believing things, and you're trying to tell them it's not real. But like, what are you talking about? It's not real. They can see it. They can hear it. So you need a lot of family support to back up with these drugs, because the person a lot of times can't live on their own because they don't live in reality. And it's probably very frustrating to be a close family member and always helping this person, and, you know, that kind of stuff, probably pretty exhausting. All right, anti-anxiety medicine is up next. All right, so anti-anxiety drugs. So let's do our definition of anti-anxiety drugs. This is drugs used to control anxiety and agitation. So you know what agitation is? We all felt agitated from time to time, just kind of like on edge, don't want to be messed with, like, just built up kind of thing. And sometimes people feel that anxiety that, oh my God, oh my God, oh my God, like I can't breathe, I can't focus, I can't. It's overwhelming. A lot of times they can be agitated too. So it kind of goes together. Probably two most famous ones. I'm sure you've heard of the first one, Xanax. People talk about it all the time. I think people actually probably abuse Xanax and stuff like that. And Ativan. Those are your two most famous or popular types of anti-anxiety medicine. Got a little video. You can always pause these and go watch those when we're done. And they work by depressing the central nervous system. So again, go back to the beginning of the year, unit 2, talking about the brain and neurons and stuff. We did the two nervous systems. We did it. And we saw them when we looked at the parasympathetic and the sympathetic. Remember, the sympathetic arouses your central nervous system, plus other parts of your body. And then your parasympathetic would like calm it and stuff like that. So this is kind of working with that central nervous system, because you can think someone with anxiety is maybe like always being aroused and they're always like on edge or that type thing. So it works to depress that central nervous system, calm it, do that whole parasympathetic thing, if you want to go back to that, so that they're not always, heart beating out of their chest, can't breathe, all that kind of stuff. They're pretty common drugs to get. Yeah. Oh, and that's it. All right. Antidepressants are up next section. All right. And let's write down our definition. So antidepressant drugs. These are drugs used to treat depression. That's where it gets the name, antidepressant. But also anxiety disorders, OCD, and PTSD. So the obsessive compulsive disorder, where the person has the thoughts, that's the obsession. So they do the compulsion, like the checking, the washing their hands, that's the compulsion, the behavior. And PTSD, that's that post-traumatic stress, like someone was in some type of trauma or something, like feeling how they feel afterwards. They actually treat anxiety disorders, OCD, and PTSD. So what they found, and I'm probably not going to do the best job of explaining it. So if you're really interested, I have some videos and stuff, but it's probably just over my chemistry understanding brain and stuff. But basically, the way they work and the way they help with anxiety is because the newer versions of antidepressants are called SSRIs. They didn't always used to be SSRIs. So they used to really just fight depression. Then when they started like changing up the medication, they were something called SSRIs, selective serotonin reuptake inhibitors. So serotonin, remember, that's the one associated with mood. And so it's selective. It's not all of them. And it's the whole reuptake back into, you remember the axon dendrite, like the axon of one going up to the dendrite of another, neurotransmitters going through, crossing that space, that synaptic gap. Instead of going into the new one, they would come back into the axon and get like reabsorbed, reuptake and stuff. And it's an inhibitor to like stop that. So I can kind of translate the words for you and get a very basic understanding of what they're doing. But when they started making drugs that did that, they found that it also helped with anxiety, OCD, and PTSD. So sometimes today people will be prescribed antidepressants and you're like, I'm not depressed. But it's because whatever's going on in their brain is similar, like chemically similar to that. And so this medicine helps with it. So they block the reabsorption and the removal of serotonin from the synapses, which is that space between the axon and the dendrite. And they're called SSRIs. Here's like a picture of it. I got this from your book. This picture's in your book. But if you go back in your head, so here's the axon. The light blue is the axon. The dark blue is the dendrite. And these are the parts of the neuron, right? So this is one neuron going to another. And remember, there's a microscopic space. They don't touch. That little space is the synapse or the synaptic gap. And so you have the neurotransmitters going through. Remember, it's that action potential and stuff like that. And so you just think it's going to go out of one and easily into the next and voila. But life doesn't always work that easy. And this is where a lot of times problems occur. So the message is sent across the synaptic gap. The message is received, but there's an excess amount of serotonin molecules. And so they're reabsorbed back up into that first neuron, the axon, the one that was trying to come out, ends up taking what's not needed or what doesn't go in because it makes like too much back in. And so basically, Prozac, did I put that on here? Oh, yeah. The famous types. Prozac, Zoloft, and Paxil. You've probably heard people say those words, especially probably Prozac's one of the most common ones. Antidepressants. Again, fairly easy to get a prescription for if needed and stuff. So the way that Prozac works is you can see it goes back up, and so it blocks it so that axon, that first neuron, can't take all the extra serotonin back. Now, why that extra serotonin hurts or what it does with depression, that's where it goes above my head, and I don't fully understand. But I see how you don't want it all coming back, so you take medicine to keep it from all coming back in, and then you don't really have the problem as much anymore. So the excess serotonin in the synapse, it stays down here in the synapse to help, like, the more serotonin you have, kind of the more, as your serotonin levels go up, so does your mood. So if you can keep it down here in the synapse, and then I guess going back in more, going into the next dendrite, the next cell, the more serotonin that'll be used, so the more the mood will go up. I guess if it goes back into kind of the old neuron, the first one goes back, reuptake into the old axon, it's not going to get used. If you don't have a lot getting used, you don't have a lot. You don't have a lot, you have less serotonin, depressed mood type thing. They're used to lift people from depression, but now, like I said, we use to treat anxiety too. They increase the availability of neurotransmitters such as norepinephrine and serotonin, which elevate arousals and elevate mood. These are what are scarce in people dealing with depression and anxiety. Usually you do require about several weeks of these to feel better. Like, you're not going to feel better the moment after you pop a pill, or the first day, or the first week. And it's a trial and error. Like, someone's depression in relationship to someone else's depression. Who has it more? Who has it milder? Who has it more moderate, more severe? Do you need to take this combination of medicine? Do you need to take this combination of medicine? Like, how many milligrams? Like, a lot, a little, certain types a day. Does Prozac work better for you, or does Zoloft work better for you? And you know what I'm saying? So it's going to be a trial and error. So people don't find immediate relief, but it's like once you get that, that setup for you, how much, what type, when, all that kind of stuff, then it works. But people just have to be patient. Sometimes that's hard because they want to get instant relief and stuff, especially if someone's really suffering from depression. They want to be lifted out of this fog and stuff. But sometimes it's a little bit of trial and error. You have to, play around with the doctor and the pharmacist, and they have to use their know-how and everything that they knew and about you and about your type. I mean, it even comes down to how much you weigh and stuff like that. It's how much you take. And they kind of put all that together to try and figure out what's the best combination for you. And usually within a month, someone starts to feel better. All right, then you got mood stabilizers, mood stabilizing drugs. Don't really have a definition for it. So let's just make that our next section, mood stabilizing drugs. I think your book actually calls it medication, but I just use the same word to keep the PowerPoint flowing. So these are mainly for people with bipolar. So somewhere put that in there, bipolar. Really interesting, I read yesterday or the day before. If you haven't, you should go look it up. Selena Gomez just announced that she also suffers from bipolar. So if you remember in the last Google slides when we talked about bipolar, I had a link to Demi Lovato talking about her struggles with it. And so it's just kind of interesting now that they both live very similar lives. I think they both actually started out on Barney and were kind of child actors, lived their life in the spotlight. They did very famous musicians. They're themselves musicians, but they also started out acting around about same age. It's just kind of interesting the similar paths they're on. And so Selena Gomez talks about, I'm sure you can find it if you hadn't already, but she has revealed that she was diagnosed with bipolar, and it kind of explained a lot of things going on in her life. And she was really high, but then would crash and have the lows. She would go to treatment, all kinds of stuff. So also write down the one that goes with this is lithium. Probably out of all the drugs we're talking about, and this is my best guess from what I know. I'm not a pharmacist. I believe this to be I believe this is the most powerful one. This most powerful, potent, strongest, however you want to call it, drug. This is definitely one that would not be mixed with drugs or alcohol. Definitely would not be mixed, with recreational drugs, anything like that. I mean, it is a chemical element, lithium. You know what I'm saying? It's incredibly, incredibly powerful. But bipolar is an incredibly strong psychological disorder that just pulls the person from highs to lows and just manipulates the person's everything about the person. The person can't stop it. It's like you're on this train, you can't stop it from like shooting out with mania to just like plummeting and bottoming out with depression. And so you need something incredibly powerful to like harness it. And so that's what this is. I think I probably told you when we were talking about bipolar, out of all the psychological disorders, bipolar has the highest rate of suicide. Couple of different reasons. A, I can imagine it's probably extremely exhausting to live this life. If you were going from highs that you and I can't wrap our heads around and fathoms to lows that you and I, again, can't wrap our head around and fathom in the span of months, nonstop, over years of your entire life, and you lose jobs, money, relationships, everything. And at some point, you're not in those manic states or in those depressed states. So you realize like what it's costing you. And you like, do all that and you go through it. But also like these people tend to throw away parts of their lives when they're in the manic state or the depressive state, relationships or like some money and stuff. So, like marriages or parent relationships or friendships. So a lot of times they get very despaired, they have such despair and stuff like that. Or when they're in a low, depressed state, they think like, what's the use? What's the point? Or when they're in a high manic state, they don't even realize their own mortality or how things could kill them. So it actually is the highest instance of suicide. And studies have shown that people with bipolar that take lithium, it drastically reduces their risk of suicide. Because it keeps them from going to those extremes. So that's a very, very good side effect. I got a video for you there. All right, next section. So that's all the drugs. We're done with drugs. One of the four, we're down. So the next one is brain stimulation. All right, and you can write this down or you can just wait till we give you some, but there's several, I didn't really have much to write, but I felt like I should have like a screen about it. There's several types of brain stimulations we're going to talk about that are coming up. All right, so the first one is ECT, electroconvulsive therapy, aka shock therapy. So electroconvulsive therapy, you can put ECT. And let's write down a definition for that. So a biomedical therapy for severely depressed patients in which, here's where it gets crazy, a brief electric current is sent, oh, and that should be through, accidentally, I'll fix that, mix the words up, is sent through the brain of an anesthetized patient. I never know how to say that word right. Anesthetized patient. You're under anesthesia. I know how to say anesthesia. I don't know how to say that word. This is where I need you guys. If we were in class, y'all would all shout it out to me and tell me the correct answer. We'd know. It is very controversial. So today's ECT is very different from ECT of the past. So you're probably thinking about a person, you'll see some clips in a minute, getting strapped down, just flailing about, just shaking everywhere, like, going through their head type stuff. And that is kind of how it used to be. It's not how it is today, thankfully. But it is controversial. Okay, it's not like people's like first step or like, oh, I want an ECT first. And sometimes people argue, is this even helping and stuff like that. So back in the day, the person would be wide awake, and they would just be jolting, flailing around, because they are being electrocuted, for lack of a better word. Not really, but oh yeah, just I guess on a milder scale. And they would receive about 100 volts of electricity to the brain. And so people were like, this is barbaric. Like, this is crazy. This is maddening, that type thing. But it was used. Today, it's a lot gentler. Patients are put under anesthesia. So first off, they're out. No memory of this. No, that's good. They're not awake, like being strapped down, like, oh my God, what's about to happen to me? They're given muscle relaxers so that they're not just like flapping and flailing about everywhere. They're just laid down. That way you don't have to tie them down. They used to strap people down because they would fall off the table and stuff. So you had to like strap them down, but strap their arms, strap their legs. But I mean, their legs are still going like this. Their arms are still going like this. Their head, they would hold their head or stuff like that. And now with the muscle relaxers, the person doesn't move as much, which is good because that's kind of the freaky part. Only lasts about 30 minutes. The patient wakes up from the anesthesia. They have no pain from it. There is no brain damage from it, but also there's no memory. And they say, I think it's like a couple hours leading up, it like erases their memory from that. Kind of weird. And it says and this, I learned about this from your book. I didn't know much about the new type. I knew about the old type, but I know kind of what it's like nowadays. And your book talks about after like 3 sessions and doing it for about 2 to 4 weeks, 80% of patients improved. And that is a drastic. That's a big number. To have an 80% success rate is pretty high. It's pretty much guaranteed. I mean, it's no like 99%, but that's really good, especially in terms of like treatment where everything's kind of guess and check, So 80% of patients improved, especially people with severe depression who did not respond to drug therapy. So people who antidepressants just could not, for whatever, get the serotonin working and just get them pulled out of it. This could help. No one knows exactly why it works. Your book couldn't even explain it. Even said like we don't exactly know why it works. We just know that it works. They were like, is it kind of a resetting of the brain? Is it a calming of an overactive neural center? Like, what is it? But it works. So here's a picture. This is the picture from your book, kind of talking about it. So they monitor people with like, ECGs and stuff like that, but they put it on their head. There's the device that delivers the shock. And they're monitoring their blood pressure. They're monitoring their oxygen. That would be like, getting what do you call it? I can never think when I'm on the videos. Where you have the like line that goes into you that's connected, and that's, the anesthesia keeping you out and stuff like that, and saline giving you whatever you would need, the muscle relaxer, the sedatives, that type of thing. So they're checking people's vitals throughout it, but you see the person's not strapped down or anything like that. So that's really good. We got 2 clips for you. One is ECT in the past. You could probably find more information on it. It's just kind of hard because back when they were doing it like that, they weren't like filming themselves doing it like that much. So this is a clip from a movie called One Flew Over the Cuckoo's Nest with Jack Nicholson and stuff. It's about 3 minutes long, and it kind of shows you what it looked like in the past. And then the other video is really good. It shows you what it looks like today. And so I watched that and was like learning so much. It's super interesting. So if you get a chance to watch those, I definitely recommend it. All right, the next type of brain stimulation is TMS or RTMS. All right, so magnetic stimulation is our next note section under brain stimulation. And the type of magnetic stimulation we're talking about is repetitive transcranial. Trans means like across cranial, your brain and stuff. Magnetic stimulation. RTMS is what it stands for. So let's write down our definition of that. So this is the application of repeated pulses of magnetic energy to the brain. And it is used to stimulate or suppress brain activity. All right. So this is where they put, basically, you'll see, there's a picture right there. And I think it was in one of the videos for psychological disorder. I think it was maybe with the schizophrenia one. Yeah, because it wasn't in there, and like the person hearing voices and stuff, they put this thing, you almost hear it click like, and it's just like doing these magnetic waves, magnetic energy, sending them pulses of magnetic energy into the brain. And don't exactly, again, know how it works, but it does. Maybe there's some type of unscrambling in there, like magnets, can unscramble stuff, or it's crazy. We actually have magnets in our water treatment here in my house because we have hard water with all these elements, I guess, you know, calcium, lime, all that kind of stuff, and they build up. And if you put a magnet, they don't stick together. And if they don't stick together, they don't leave hard water stains. So it's just crazy all the things magnets can do to kind of like break stuff apart or unscramble it or something. So I guess it's doing kind of the same thing in your brain of like mixing stuff around. I know. I should have went to med school. I know. So anyways, there's an article and a video you can watch on it, but it's definitely interesting. So the person's awake. They're just sitting there. There's absolutely no pain. It's just there's a magnet back here. And it kind of takes away like the risk of seizures, the risk of memory loss, and other serious side effects. So it's not quite as strong as ECT. I mean, putting electrical currents through someone is a lot stronger than just like having a magnet do some pulses behind them. So it's you know, much less. And then the last type of brain stimulation is deep brain stimulation. You want to make that your next section. I don't have a definition for this, but I do want you to write some stuff down. So like what deep brain stimulation is, if you watch this video, they talk about it. They call it basically a pacemaker for the brain. So if you want to write that down, pacemaker for the brain. You know, a pacemaker is what a lot of people wear, and it's, you know, on their heart, and it keeps their heart beating on beat, you know, not getting too fast, too slow, you know, whatever irregularities they have. So it's kind of like that. They put these electrodes, basically these things, into on your head to go into your brain, so they can like go deep down into your brain, stimulating it. Yeah, all right. Kind of a bad definition, I know, but there's, you know, this neural hub where your frontal lobe, you know, in the deep center of your brain's all that stuff with the limbic center where your emotions are, and the frontal lobe kind of backs up to it. So like where they connect tends to be overactive in a person with depression, which is weird because you think depression like no activity, but for some reason it's overactive, which maybe could lead to the no serotonin or something like that, right? So they stimulate that specific area with like electrodes and stuff. So a video you can watch on that. All these usually are an article with a video, so you can read the article if you want. If not, just skip down, scroll down, watch the video. It's really good. About a third of people responded well, and about a third of people responded like moderately well. So 2/3 of people this worked for. So again, that's a pretty good success rate. All right, psychosurgery, third section. So we did drugs, we did brain stimulation. Now let's talk about some surgery. And the type of surgery is related to psychology, so psychosurgery. All right, we got a definition coming up. So psychosurgery is surgery that removes or destroys brain tissue. So you're either removing part of their brain, destroying part of their brain. Brain tissue in an effort to change behavior. This is last resort. This is permanent. This is one little slight mess up and it's over for the person. You know, this is very, very controversial and very just like I said, just like last resort, because you can't fix it. And if something gets messed up, you know, that type of thing. There's a couple different types. This is a really, really good video. Go watch this video. I'm pretty sure I can't click it because I'm doing this. Pretty sure that's the one from, yeah, the New York Times that talks about a bunch of different types, especially a lobotomy that's coming up. So go watch that video. It is the most drastic of all the biomedical techniques. It is the least used of all the biomedical techniques. Today, there are some precise psychosurgeries they do, like if someone's having OCD or problems with OCD, there's maybe a pinpoint a part of the brain that's like really overactive and try and with surgery kill some of that tissue. If someone's having seizures, they do like brain surgery and stuff, but this is not something people want to do. Very risky. And only if they could pinpoint the area of the brain. But like I said, it's irreversible, it's controversial, that type of thing. The main type of psychosurgery we're going to talk about, because the main one everyone thinks about, is a lobotomy. So let me tell you about it before you write it down. First off, I would not just Google lobotomy. Trust, I did it last night when I was making this PowerPoint. Not something you want to do after midnight. And the videos and stuff, like, watch at your own risk. I searched for pages to freaking find a video to put on here that you guys could watch because they were not good. They were not good. Here's how a lobotomy works. Okay, I'm gonna tell it to you. You got your picture right here. It's called ice pick surgery. They used to take an ice pick, which is something long and sharp, and they would The person was not anesthesia, like not under anesthesia either. The person had to be awake, which is crazy. And they went up through the eye socket, straight up into the brain, and basically where that frontal lobe kind of meets that limbic center, somewhere in there, they just, and it tore the tissue, it broke the connection, whatever you want to call it. And now those parts of the brain can't communicate because they're not together anymore. And voila, the person's fixed, right? Because their judgment and their behavior and thoughts and stuff are not getting to their emotions and making them crazy or whatever you wanted to call them. So people did this. This was like when it came to America from somewhere, I think it was Europe. I don't think it was like South America. Somewhere. It was like hailed as like a miracle treatment. People were doing it left and right. Anyone who was like over emotional, overactive, bad, wouldn't calm down. I mean, think of all these variations of behavior people could have that are just maybe not like the easiest or the best. Is like, you're too overactive, you cry too much, you're too this, you're too that, you're too much, basically. They would just, and it's like a quick procedure. I think a lot of doctors thought like anybody could do it. And yeah, you just put the ice pick up, wiggle it around, and then the person's awake. And oh man, like when you Google it, the pictures of people afterwards or during, or this is why I'm not a doctor, because I can't even. So learn at your own risk. So yeah, so that's a lobotomy. They do not do them today, thank goodness. I don't know, maybe some parts of the world scarily still do, but hopefully really nowhere does these much today. Because they had really drastic effects. So the most famous one, it talks about it a little bit in your book. You may have heard about it before. It's a lady named Rosemary Kennedy. Rosemary Kennedy is the sister to President John Kennedy, the sister to, if you've taken U.S. history, slain U.S. Senator Robert F. Kennedy, who was Kennedy's brother, running for president in the late 1960s, killed like with Martin Luther King, the whole civil rights movement. Senator who just passed away, Ted Kennedy. It was their sister. And she was said to be very emotional. I don't know that she necessarily had psychological disorders. Perhaps she did. I mean, it was when all this went down, would have been like, I don't know. He was president in like 1960, and this would have happened when she was like a young girl. So this could have been the 30s or 40s. I don't know if it would have been earlier, but anyways, it was a long, long time ago. And so they wouldn't have really diagnosed psychological disorders back then like they do now. So just kind of keep that in mind too. So I don't know if she had a psychological disorder or not, but she was said to just be a lot, very emotional, cried a lot, got very excitable, very happy, very loud. And see, I think this family, like, so the dad was supposedly, if you haven't learned all this in U.S. history, I won't bore you because I can talk for hours on this. But it's like the dad was grooming the firstborn son to be president. They were very rich, very prominent family up north, Catholic, Massachusetts. And the first son goes off to World War II, gets shot down on a plane and dies. And so the second son then kind of takes over the role, and that's John F. Kennedy, who then becomes president. But Rosemary was older, and I think she was just kind of an embarrassment, according to the dad, was just like an embarrassment to the family. The family was just very like put together and wealthy and, you know, elite, and she was not really acting the part. So against the mother, I don't know if it was against the mother's wishes, but I know it was without the mother's permission. So this is like kind of a huge thing. The dad just took her to get one done one day. And I don't know if they botched it or if this was just what always happened when people got it. But I mean, it did take away her emotional state because she basically became like no emotions, kind of zombie-ish. Not zombie-ish, but you know what I'm saying, like robotic and stuff. But it also really affected her mental capabilities. And so I don't know if that happened with most people, but I mean, yeah, your brain, think how much your brain does. Like you're off by a millimeter and it's the wrong thing. So she had very diminished. I mean, she was like childlike, infant, like she was, you know, handicapped for pretty much the rest of her life, had to be taken care of, went to an institution. So that's what they did back then, to take care of people physically and mentally. And so kind of interesting story. Another sister, there was like a lot of brothers and sisters of JFK. Another sister, which is a lady named Eunice Kennedy, she just kind of recently passed away. She is the mother of Maria Shriver. I don't know if you guys know Maria Shriver. Maria Shriver is the one who was married to Arnold Schwarzenegger when he was the governor. And he cheated on her. And she's like a TV news anchor. She's kind of her own awesomeness. So anyways, her mom, Eunice Kennedy, a sister, ended up kind of seeing what her sister was going through and other people at the mental hospital and other people who were mentally handicapped, physically handicapped, kind of that, because she was really close with her sister and involved. And she ended up starting the Special Olympics for them. So that was really cool. So if one good thing came out of the story, that came out. And so, yeah, the Special Olympics kind of came from this. But that is because the woman had a lobotomy and ended up in that state, which is pretty crazy to think about. So, yeah, they're not done today. But, anyways, and like I said, Google at your own risk. But we do have to write it down so you know what it is. So, it's kind of a long definition, but lobotomy. All right, so lobotomy is a psychological procedure. No, psychosurgical procedure. So, psychosurgical procedure, once used, it says clam, doesn't it? Should be calm. I'll fix it. Once used to calm uncontrollably emotional or violent patients. So that's kind of your main definition. This is kind of the second part of the definition is explaining what it is. So the procedure, cut the nerves, like severed them, connecting the frontal lobes to the emotion controlling centers of the inner brain. So yeah, cut the connection. And if you want to put not used today, you can put ice pick surgery if you want. Controversial. Harmed people. See, I'm writing all these things down. Harmed people, like psychologically, but also like mentally. It took away like intelligence. Yeah. All right, and then the last of the 4 is just doing a therapeutic lifestyle change. Therapeutic lifestyle change. So you can take medicine, you can have brain stimulation, you can have a surgery, or you can try these things. This is the easiest to try. This is cheapest to try, all that kind of stuff. So basically, it's trying to change up parts of your lifestyle, like exercise, nutrition, diet, the relationships. Like, are you in positive relationships? Are you in healthy ones? Are you in toxic ones? Are you getting exercise? Are you eating good? Are you getting out and about, recreation? Are you having time to relax? Religion, spirituality, sunlight exposure, like sleep patterns have to do with your mental state and more. And so it's basically looking at those components of your life and figuring out how you can tweak or adjust them, fix them, make them better so that maybe you could help, fight off whatever psychological disorder you were suffering from. So I would list these. If you don't want to list them all, that's okay, but definitely list some. So that you know like what it is we're talking about that you could change. It promotes physical activity and social engagement to prevent and treat psychological disorders, basically. So I'll move that up. So take a second, write some of those therapeutic lifestyle change components down, like those lifestyle components. I'm actually going to keep going. If you need to pause and come back. I think we just got like 2 slides left. Woo-hoo! All right. So, yes. All right. So, preventing psychological disorders and building resilience. First off, it's better to prevent something than to fix it. If you can like prevent a house fire, it's easier than putting out a house fire and saving the house and rebuilding the house. Okay. So, prevention's always best. So, if you can do some preventative measures, if you know that something could trigger, if you want to get those lifestyle changes, in track so that you're sleeping well, eating well, stuff like that, just so that maybe, psychological disorders don't ever even manifest. Like I've told you a million times about my friend, she doesn't know how predisposed she is to schizophrenia. She knows her biological father had it, so she knows it has a strong genetic component. It's in her somehow. Is there a lot in her and a little thing could trigger it? Is it barely in her and you need a whole lot to trigger it? You don't know. So you trigger it. Then it's too late. She's very preventative. Like I said, she doesn't touch alcohol, drugs, smoking, nothing. She does not do any of those things. She's very careful with her stress and all kinds of things. She manages those things very well because she does not want to trigger something. That would be like preventative. Like if you know people in your family genetically suffer from stuff, so you take preventative measures to maybe like, keep it from ever happening. Now that's not to say it's going to be 100%. You could take a lot of preventative measures. Somebody could still break into your house. You could lock your door, somebody still break in. So it's not to say it's 100%, but it could help. It could keep it. So that's the first part. And there's people like community psychologists, and they study this stuff. They see that people's environment, what they're around, contributes to psychological disorders. And so they try and make environments that like promote psychological health, basically. And then you just got two last things you're writing down and we're done. So it's talking about building resilience. So let's write down what resilience is. So resilience is the personal strength that helps most people cope with stress and recover from adversity and even trauma. So resilience is like when you build yourself back, bring yourself back up, like you're resilient. You don't get knocked down and stay down. So people with psychological disorders need to be resilient. Like they had a bad week, they had a bad month, they had a bad whatever season of life, but they're getting treatment and they're trying better and they got out of this relationship or this environment or they're taking this type of medication or something. So it's to like not let yourself just like stay down and out. You know what I'm saying? So that's resilience. Like an example your book talks about is like, you want to think of like a famous example, think of like New Yorkers in the days, weeks, months, years following 9/11. They rebuilt themselves. They built themselves back up. They were patriotic. They were prideful. They didn't let it just like, when the Twin Towers fell, they didn't just like go off sulking and moping, being like, well, they got back to work type thing. And then post-traumatic growth is the last thing. So post-traumatic growth. The definition of that: positive psychological changes as a result of struggling with extremely challenging circumstances and life crises. So positive psychological changes that result. So if someone went through some type of trauma, some type of struggle, some type of like, break from reality with a psychological disorder, something like that. When they come out of it and they're better and they've been resilient and they're doing okay and they're taking their medicine and they're in healthy relationships and environments and stuff like that, they're very grateful for it. And it's just like the positiveness that comes out. So maybe they use it to help other people or tell their story or stuff like that, because they went through some very serious stuff. They've made it out to the other side and it's made them a better person. They want to share that to help other people. So like an example would be, your book talks about like if someone was a cancer survivor, when, they beat it and they're recovered, they have a greater appreciation for life and stuff like that. That's it. Give yourself a round of applause. You are done with the notes for Unit 8, Psychological Disorders and Therapy, and we're good. The next thing, I'll try and say this on the videos, it's written on the website, make sure you do your therapy chart.